gals, and we're live. We're live. Hello, healthcare. Hello, LinkedIn. Hello, YouTube. However you are joining us for this webinar today, we are excited to have you. And this conversation, you might notice we've been talking a lot about things around consumerism and kind of the nexus between the consumer experience and healthcare technology. This is an interesting conversation because our guest today, Dr. Matt Cybulsky, sits in a domain that covers all of those things at the same time. So with his consulting firm and work that he's done in the past, he focuses on behavioral economics in healthcare, but also has a background in healthcare administration. He's led healthcare administration, even taught classes on that at UAB, as well as healthcare finance and financial technology. So it was really exciting I was having a conversation with Matt a couple of weeks ago, and he was talking about some of the more recent innovations in financial technology and how they apply to this changing landscape within healthcare. So thought that it would be a good idea to expose the audience to some of the things, like as we're going through at the same time, healthcare.
Yikes.
I'm sorry, what?
Expose them. Yikes. Look out.
But to be exposed to these technologies and that kind of intersection between financial technology, behavioral economics, and patient engagement. So, Matt, I wanted to brag on you for a few minutes, but now you can brag a little bit too.
What am I bragging about? What I'm involved in?
Yeah. I just wanted to say hello to the audience.
Well, hello, audience. It's good to be here. I am very grateful for my friendship with Chris Hemphill. It goes back all the way to, I think we were introduced 2012 in Birmingham, Alabama at a dinner location and immediately hit it off. Bright mind, curious mind, growth mind. Yeah, it's nice to build community with you, Chris. And it's also nice to meet you, Audrey.
Hi there.
And happy to have Audrey on. Audrey actually works along with me at Symphony RM, and she has a really big enthusiasm for consumerism within healthcare. And I just thought it would be this would be a great connection to have for the audience. So for the folks out there watching, if there's any questions that you have or any kinds of issues that you might have been trying to address around patient engagement or around digital health or anything that we're discussing, it's designed to be an open conversation. We use LinkedIn Live for a reason. I was talking with Matt. He's excited to answer any kind of questions that you have. So I want to say hi first to Elia here, and anybody else who wants to chime in. We're happy to have you. Before we get started, too, I just wanted to point out that for those who are interested in what some of the latest things that are going on with regards to healthcare consumerism and a lot of the new changing care models that we're seeing from organizations like Walmart and CVS and those other organizations, that so-called disruptors within healthcare, we actually recently put out a podcast on our website, hellohealthcare.com. where we go deep with, on this subject, Dr. Paul Keckley, James Gardner, Sherry Campbell, and many others with regards to what these organizations are doing and how conventional healthcare providers might be impacted by some of the more recent innovations. So just wanted to point out hellohealthcare.com for folks who aren't following the podcast. Awesome. But with all that, thanks, Matt. And with all that, just want to go ahead and get started. So we brought up an interesting background, an interesting set of things that you're doing in healthcare finance, administration, behavioral science, and that's obviously a really rare but interesting combination. Just curious about any background on why you've taken this journey and what's been keeping you going along the way.
Yeah, so it's a good conversation. I get asked that quite a bit because it is somewhat of a synthetic career path I've taken. I have always had a great interest in human behavior. I mean, I don't know who isn't, right? Like it's really, if you look at majors for psychology, for example, I think they're like behavioral sciences are some of the most popular studies you see out of universities these days. But for myself, I was working in revenue cycle a while back and was noticing a lot of interesting sort of patterns with how patients interacted with things like their EOB from insurers, or how they pay their bills, or how we interacted with them on the phone or through any sort of correspondence. I became curious enough about it where I thought, man, I wonder if there's some innovation to be had with our interactions, beyond the software that we had to process any sort of financial transaction or adjudication from an insurer. How does our patient body themselves, what can we do with them as far as innovating our connection with them when it comes to their satisfaction, keeping them in our sort of community of providers, how they are perceiving their interaction with us has to get beyond just the clinical space or the procedure space. It became something I started thinking a lot about. And then I thought, well, how do you measure that, or how do you discover that? So I had a conversation with some executives where I was working and made a proposition. I said, there's some studies going on right now that are getting quite popular. They're calling it behavioral economics. And they study how humans sort of participate in economies and how they participate as consumers, but through the lens of what we know about human behavior. So that proposition got a yes from one of the executives I was speaking with. And I kind of yippee-ki-yayed to get a deeper study into human behavior in the context of healthcare participation and finance. So how do patients interact, and how do you study that, and all the things that I had to do to learn that. So I did a PhD in behavioral sciences. It was really successful in what I discovered, enough to confer the degree, and then started doing some consulting work. I worked in some quality and safety places, which is interesting foray. I did that at an academic institution. And then I moved on to doing some work with my own consultancy and direct consumer work. And that became really fascinating. So when you send patients devices, how do they interact with it? How do patients and providers interact through telecommunication, through digital means? And how do you influence that behavior for all number of things, right? When it comes to quality and safety, or it comes to satisfaction, or it comes to follow through, or it comes to the pills show up on the doorstep, and did they open them and take them at the regular intervals they were prescribed, or did they stay in the cupboard? And then how do you move the needle on any of that? And it has been quite an interesting journey. So it started off just with curiosity, and then it became formal training, and then it became applying tool sets to remote care with patients through digital means. We ended up starting our own podcast. And, to be honest with you, I started it with a friend of mine just to have a reason to reach out to someone I had no business speaking to. Reaching out to Eric Topol, reaching out to Lou Levy at Teladoc. And then it just ballooned. It became quite popular. And we were focusing on conversational AI and voice first technologies, like Siri, Cortana, Amazon's product, et cetera. And we started out with like 300 listeners and ballooned to over 15,000. And then next thing you know, we're doing conferences at Harvard Medical School. And now we've moved the podcast to Twitter Spaces, where we have dialogues and panels with experts. And we always are talking about the human interest story. Digital health is nothing without the human story. Okay? The gold standard for me, if I was a provider, would be to be in person with you. But because of a shortage of providers, an increase in costs, COVID-19, we've had to accelerate the silver standard, which is how do I connect with you through any sort of medium in order to enact a healthy behavior, a healing modality, or a relationship. And that relationship is sort of the nuts and bolts of what healthcare is, whether it's on the fintech side or the clinical side, or through direct consumer care, which, I would even consider a company like Peloton to be a healthcare company. It just has a closed community of people who can receive messages and take on a cultural identity of health and well-being. Those are all the spectrum of things that I've been involved in and then want to be involved in. But it started with just a question, and it became about measuring an impact, with dollars and volume on small behavioral changes that we sort of started looking at. And then it ballooned into a podcast that would help me get consulting work, which then became me being known as a guy that interviews people doing interesting things. And that's how this even event here is taking place. Chris, you've come to some of our events and you've been a part of our podcast, and we've talked extensively over the years about the value of building a community. And that community building is no different from my research on human behavior as well. So anyway, that's my history, and not a very short summary.
Well, thank you for providing the background. There's a whole lot of interesting stuff that we could go into on that one. And I think we're going to start elucidating that throughout the conversation. One point that really stands out is the question on the strength of relationships, how you look at quantifying that through a behavioral science lens. And I think that a lot of the conversation around digital health and that nexus around fintech will help bring light to that. Just to start getting into it then. So in these conversations, even today, you've spoken about this kind of nexus between digital health and financial technology.
Yeah.
So to dig deeper on that, what's the top challenge that you see these types of technologies addressing?
That's a hard question, Chris. The top challenge, top lists, and the most important thing sort of violates, my own worldview on problem solving, which is it's never just one problem. It's a cadre of problems that you're addressing. There's a spectrum. So I won't contend that I think I know what the number one issue is. What I will say that I'm focused on quite a bit is sort of like a consistency of messaging along with sort of intrinsic motivation. So how do I, get a connection with patients in order to keep them interested enough where I don't fatigue them? They feel like they're part of the continuum themselves as a co-teammate of care. That is an important takeaway, right? That they don't ignore me, that I don't fatigue them, that they don't feel harassed, but they feel like the interaction is easing some part of their continuum of care. They're a participant in that. And that comes from a lot of looks at the UX, right? The user experience, the interfaces that we're using, coordinating messaging to patients, and then also inviting them to participate in some way, whether that's a payment plan, point of service collection, follow-up care, having some interaction, whether it be a conversational AI tool or human, about the next steps in their care. I focused on fintech quite a bit lately because that's majority of those interactions are going to be with pre-service and then post-care follow-up, right? Getting my prescriptions at the pharmacy, paying my bill, understanding my bill, understanding what my cost share might be going into a procedure. Now, the clinical and patient relationship, of course, is really important, right? The reason I'm going through this process is because of my health in one way or another. But there's a lot of touches, to use an industry term, for a patient that doesn't involve the actual clinical hands-on procedure, modality, you name it. But that still impact the way they feel about their health, their care, and the burden of it. Money is time. Time is also burdensome. And money, without it, can make things hard, including taking care of yourself. So that is a large place where I'm looking a lot, is how do I interact with them in that regard? How do I coordinate systems so that they can join a payment plan if it's expensive, or that what they owe after insurance doesn't impact their credit and keep them from being able to house themselves efficiently, or drive their car to the grocery store, or have disposable income so they can buy healthy food, right? So these are sort of the indexes that I work upon right now. Beforehand, I was doing a lot of work on, if I sent Chris and Audrey a device to help monitor their health, how do I get them to open it, interact with it, put data in it? What are the UX, UI considerations I make there so that the thing they're monitoring is influenced and impacted in a way that gives them a healthier life? Money can give people a healthier life. Managing it can give them a healthier life. Not having them harassed gives them a sense of connection to the healthcare provider or system that is endowing, right? they're part of a community, and that community can lead to a lot of success. So that's where I'm focusing a lot right now.
Excellent. So the way you launched off with regards to the communication without that exceeding into harassment, like there's a lot of conversation around frequency and how we interact with people individually. And Chris Saxman, I popped it up on the screen earlier, but Chris Saxman had brought up a good point around treating people as individual consumers and how certain strategies that work for one person might not work for another. So just curious, there's a whole world of engagement examples that opens up, and I'm curious if there's any kind of like story from the past, like in that patient engagement perspective that you might be able to expand on.
So I think what Chris is saying resonates. It'll resonate with everybody. I think the risk with tackling a problem like Chris is defining is not falling into sort of a relativistic world, right? Where everyone's so unique that we can't develop a pattern to deliver. That's a challenge. That is not a criticism of Chris's comment at all. It's sort of a yes, and how do we create like at least an 80-20 to move the needle a little bit? So number one, yeah, I agree with him. I think AI and digital connections can turn into eventually a gold standard as the technology increases. So I appreciate his comment very much and his interaction. So as far as like a use case example, I actually spoke about this recently. There is a great story about some incredibly adept and experienced technologists who were creating a voice first tool, a conversational AI tool for a man who had some disabilities due to a chronic condition. Met with the guy, kind of looked at his living situation, learned about him as a human being, his interests, music, art, etc. Looked at where he lived and tried to come up with some tools to help him live better, given his limitations. They went back to the drawing board. They spent a great deal of time working through their own sort of pedigrees. And these are well-trained Ivy League folks, MIT, Harvard, RISD out of Rhode Island. So they came up with all this great stuff, and they went back to him and said, hey, here's all the things that we can do for you. And he says to them, and I'm paraphrasing, this sounds great. This is wonderful. Y'all are obviously very talented, but the number one thing that I want is not to die alone. And the big fault so many times in technology when it comes to healthcare is you neglect to ask the patients what the heck they want. And this guy's scenario was, I don't want to be alone. Can you create something to help me not be alone? There's a lot of other tools I have. I can feed myself. I have people come to help me clean up, shave. They buy my groceries, but I don't want to be alone if I'm here and I think I might be dying. And the conclusion they came to was this man's desires and passions were music. So of all the complicated things they made, they ended up going back to something that was already easy to create and apply, which is creating a wake word that initiated a playlist of his choosing. So in case he was actively dying, he could kind of cry out or speak, and this playlist would play. And this music would remind him of family, of memories, of lovers past, and he was not alone. So according to Chris's comment about the uniqueness of these things, nothing's more human than that. And that story to me is one of these great examples of uniqueness using a tool set that isn't particularly unique per person, but has tool sets that can be segmented for needs. Sometimes the answer to connection and building community with patients and creating innovation is a lot more simpler than we like to make it out to be. And that is one of my favorite examples when you work with a group of innovators and say, there's a lot of things you can do, but what you ought to do can easily and should be influenced by the patients you're delivering for. So ask them first and then go to create.
That's a really touching story. Thank you for sharing that, Matt. That gets me. I was thinking of another technology I wanted you to comment on. It's top of mind for me because I just started using it. but I am using Noom. Which is an app that pairs me with a coach and helps me to, I can track my food, I can track my exercise, and it kind of color codes. But one of the things that was particularly striking to me was the language used. It's very geared toward millennial. There's a lot of hashtags. They've referenced Harry Potter at least 2 or 3 times, and I think I'm on lesson 3. But they're really speaking to my generation, I think.
Yeah. So what works for you with Noom, right? Like there's a bajillion apps on my phone. Like there's so many apps on my phone. I've gotten good at like categorizing what I click on to make it fast or using the voice interface. So what makes sort of this messaging tool set, what creates the intrinsic move for you? Like why is this working opposed to you just saying to yourself, I'm going to write down on the whiteboard on the fridge what I ate and how much I weighed today and how much water I took in. What's different here?
So I'm really holding myself accountable to a large audience right now.
Only share what you
I'll be very vulnerable to share. So I've tracked my food for about 10 days in a row. Yesterday, had kind of an off day. I got kiddos that are sick and I made probably shouldn't have had that sandwich, maybe. And I had a big Italian sandwich and I didn't want to log it in my own little way. So I ignored my app and the app prompted me with a notification. And then maybe in the afternoon. So several hours after it realized I hadn't logged a couple meals, my coach messaged me and just said, hey, this is your SOS. Back when you signed up, you said, do you want someone to check in with you if one of these things hasn't happened? So I did self-select into this and someone wrote to me and I logged my darn sandwich. So that worked. Yeah. I don't know if it's going to work every time, but it was a very effective intervention.
Yeah, that's something that I've applied a lot in the past, like social proof. So, a lot of times the things that we do, how we dress, how we speak is social signals to the tribe of people we claim to show identity toward, right? There's a certain kind of people that are going to join LinkedIn for this talk. There's also a huge swath of the population that's never going to hear about this nor care. So finding out the community standard and being influenced by that's really important. This is not necessarily a patient-focused example, but there is great examples in sort of rev cycle world where you have teams of people that are responsible for certain parts of the rev cycle, right? Insurance debits, insurance AR, correspondence with insurers, and they work in groups. Those groups don't always interact with each other. But to optimize performance of those groups, instead of having a manager or someone top down say, here's how I recorded your effective work, and this is what I need you to improve upon, you can look at the teams themselves and say, we're going to rate you guys as teams and tell you as a team where you're succeeding and where you're failing. And by the way, there's some bonus tied to that. And we're going to share that individually in groups with you, help each other get better so that you all can get this external incentive. So you're sort of combining this internal motivation of, I want to do right by my community, my team, with if I do that and I do that effectively, which is not that hard, right? Because I'm wired as a human to be pro-social with a group, then I also get this external reward. The internal motivation to be pro-social and have your teammates say, good job, trumps the external motivation of any dollar or treat you might get for following through with that. I think the similar thing is true with you, Audrey, or anyone using this tool you're talking about. There's a community standard that you're developing, and there's a sort of a tribal code that you're running by. And the satisfaction of that from evolution for you and as a human being probably is incentivizing you to be aware of the things that you're putting inside yourself or creating opportunities for physical fitness or sleeping right. Both of those things together is kind of a powerful drug. In fact, the internal motivation that we can create in others, if we set up systems right, will win, as Dan Pink says, in a heavyweight bout against extrinsic motivation every time. So I try to think about that with every problem in innovation. How do I create whatever I'm creating with whatever firm comes to me that focuses on internal motivation of the human or participants that we're working with?
Yeah, and I think one critical piece, and you've said the word a number of times, is connection. I felt a connection, and had that human not reached out to me, now it could be a robot. It not maybe doesn't necessarily need to be a person, but I did feel a connection with another person that incentivized me to, or guilted me perhaps. But I realized, gosh, I need to interact with this. I should log this.
Yeah.
So
Awesome.
I think something great's happened here where we started off talking about the grand landscape of digital health and fintech. And then we zoomed in on a patient example, and then we zoomed in on the Noom app example, and then started getting really specific on levers of influence. Like I like the fact that you called it out specifically as social proof, mirroring the book Influence by Robert Cialdini.
Yeah.
What I wanted to get into, Laurel Skirko, actually, she asked a question here, and I just wanted to give her a shout out first of all, because Laurel, like my introduction to her was while doing this show, and now we're coworkers. So she's recently started to work with us. But so we've talked about this overall landscape of digital health and the levers of influence on how to drive behaviors. So her question kind of leans into, okay, so we have this influence, we have this engagement here. How are companies looking at this and actually valuing it? It kind of goes in line with how leaders can push consumerism-driven efforts within their own. How are they looking at this from a value perspective?
Well, it's a great question. And once again, I'll caveat all of this. I don't have all the answers, but I have a unique view. Laurel's question is spot on. And one thing that comes to mind here is, we're bridging this gap between provider to patient, right? If I got a panel 1 to 4,000 for a year and I'm a general practitioner, maybe I can manage that pretty well. But if I've got 9,000 patients, or I've got 20,000 patients because of whatever system I'm set up in, or because there's a shortage of general practitioners with the increasing need of people to have connects, we've got to build some tools that allow that practitioner to shorten that ratio where it's more connected or that there's more influence. And how do you do that? Well, creating tools for patients to monitor themselves and do something on their own, similar to what Audrey's talking about, but much more expanded. And you can do that by condition, right? Hypertension, diabetes, hip fracture recovery, dementia. There's all kinds of applications with that. But those are the two big takeaways for me are large companies and healthcare companies are using digital means for patients to help themselves, but also to bridge the gap away from the gold standard, which to me, the one-to-one care is the gold standard. Me showing up to your house and cooking you a meal, showing you how to work out, putting you to bed on time, making you take your drugs, like that can't get better than that. But if I have a human stand-in, an AI tool, a cell phone, a mobile technology, a smart speaker in the house, monitoring when you have your coffee, when you go to bed, how many times you're opening the fridge, how many times you're flushing the toilet. If you've got COPD, congestive heart failure. If I can have microphones in your house and know how many liters of urine output or sewage is coming out of the house, I can get a sense of how much your output is, and maybe if you're managing that or not managing that. So back to your question originally, instead of like framing the problem. Let's look at something like access, healthcare access alone. There are a limited amount of family practitioners. I had a podcast with the AAFP leadership recently where we talked about that and a campaign of their own to sort of recruit and grow residents for family practice to sort of keep this ratio of provider to patient better across the board. There's also a CDC initiative for social determinants of health when it comes to how many people have an active relationship with a PCP or primary care provider. There is only a finite amount of humans involved in that. So to bridge that gap, you've got to use some technology. And why is that useful for a company? Well, if you think about an insurer, for example, any kind of insurer, the more patients that are connected, either through a digital means or to a physical person that's a PCP or a primary care provider, studies have shown, right? The longer we push out chronic condition diagnosis, the longer we stabilize someone who has a chronic condition and keep them from exacerbating. There is a quality of life component with that also, right? So it's not just about money, but if you are ill or you are older and are, coded in your DNA and your environment to end up with something that is going to need management. How do we do that in a way that keeps your quality of life as high as possible? So this has to drive and does drive a lot of digital health. The direct consumer health companies, him and hers, folks, Peloton, as I've mentioned, Roman, these are limiting to a degree because they are out of pocket, most of them, right? There are disposable income. So if you just look at something like out-of-pocket costs required for an insured person, up to $5,000 a year, that's a limited volume of dollars per consumer. And then there's also very unique sort of applications that each consumer are going to go and buy themselves. So, the direct consumer market compared to the insured market is small. Now, I just heard this morning of a company that is extending remote care to Medicaid insured folks. They got some funding, and that to me is pretty exciting, right? If you're talking about moving a needle, if you're talking about quality of life, if you're talking about a limited amount of providers per person, or even provider deserts. There are parts of cities, huge American cities, that don't have primary care or an emergency clinic or an urgent care clinic near it, right, in walking distance. So this is something that, to me, is what digital health companies ought to be looking at and are looking at. They're not, for us to have this conversation to say that people aren't looking at these problems, there's a ton of capital going into it, and there's a lot of smart people considering it. But that's social determinant of health for access alone is a great example of where digital health firms are sort of applying themselves. So there's monitoring and there's bridging the gap of ratio from PCP to consumer, all in the name of quality of life. Secondary claim is to curtail excessive healthcare spending.
Yeah, I think we've been talking about these chronic conditions. This has been a story for a long time. What has been happening that you've seen healthcare companies do, or these direct-to-consumer companies do, that hasn't worked? What can we rule out, and where do we know we need to trend towards?
Moralizing and getting shoulds all over your consumers. And what do I mean by that? Just because I send you something that's going to make your life better, according to me, does not necessitate you using it. The patient should do this. It's the right thing to do. Now, patients act in a certain way. Discover what patient segment behaviors are prominent in what you're trying to influence, and then create a product around that. Stop expecting people to be these sort of moral soldiers, even for themselves. Expect humans to act like humans, discover how they behave, and then create systems around them. How do you do that? You lower barriers to access and barriers to activation for devices or for interaction. You look at social proof a great deal of the time. You consider that the human model is to be lazy and not to really do a whole lot of anything. So creating models around reducing barriers, the cost of action, which humans want to sort of be misers about. They don't want to spend that energy. That's where a lot of folks go wrong. Goodwill is the chief aim of medicine. It is. But the reality is, when it comes to direct consumer work, any product or service that's expecting the patient to carry a whole lot of that burden themselves is going to fail, in my opinion.
It makes sense. Can you talk about one of the health systems that you've worked with that is really thinking about the customer experience on the rev cycle side, and what did they do that has worked?
So that's an interesting question. I think the innovation for rev cycle when it comes to how consumers are interacting is interesting. So I'm not going to necessarily name some of these folks, but there are some firms that are interacting with patients that do take a human behavior approach first. A lot of it, I've seen the innovation has been with their UX or even their sort of texting campaigns. So how are they communicating with these patients? What does it look like when the patient engages? How easy is it to navigate their tools? Are you putting patients through a laborious login sign-up process? Or, are you using data and consent and assent from other systems allowing someone to put in a birth date or use a Face ID in order to interact from like a rev cycle capability. The third place is conversational AI technology. Iterative communication through text is okay. It's definitely better than some other tools we've seen. But how many of those can field real questions from a patient? Why do I owe this? And having a conversational AI respond and say, oh, you owe it because you had this data service, and here's the EOB, and this is the insurance we have on file. By the way, here's a link to go look at the bill again if you wish. That sort of communication that sort of supplants human wisdom is a big win for rev cycle companies that are trying to apply innovative tool sets. The other part is, I've heard of some firms out of the Bay Area, a company called Acasa, a friend of mine, Ben Beadle-Ryby, got started. They've taken on some funding, and they are purporting to have a technology that's artificial intelligence driven rev cycle. So on the system side of rev cycle, how much AI are we applying to decision matrices when you interact with a payer? That's fascinating, right? So all in the name of speeding cash, reducing mistakes, reducing denials, stabilizing labor costs over time. AI being introduced to revenue cycle is an exciting thing to me. It is also a Herculean effort if you think about what might be considered in some experts' minds the infinite amount of variables that exist in any sort of rev cycle process. It takes a lot of wisdom. It takes a hell of a lot of human experience in order to pull off a well-organized, well-operationalized, efficient rev cycle, cohort or department. So I think the AI application has got me pretty excited.
Matt, Dr. Cybulsky, we got another good question from the audience, and I think it kind of synthesizes a lot of the things that you've been talking about today around influence. This again from Chris Saxman, but the gist of the question is there some thinking? Is there a framework that people should consider when creating something that people would want to use eagerly? He cited Peloton as an example of something that people are eagerly hopping onto, literally, but just wanted to get an idea on that kind of framework that people should consider for eager consumption, going past the moralizing aspects of it.
Sure, great question. Chris is a ringer today. Lots of wonderful interactions. Thank you, Chris, for listening. I hope you're enjoying your coffee and smiling while I say that and highlight you. There's a great book that was written not long ago called The Myth of the Rational Voter. And this book was about voting, but there was a really important human component to that, which was humans are really going to be more interested in things that cost them something. Humans are not as interested in what they gain from it, right? This is the famous Thaler maxim that was used for his work that conferred upon him the Nobel Prize. Humans are 2 times as much concerned over what they'll lose from their status quo as to what they'll gain. So when you apply that to sort of a direct consumer or health tool, humans are going to think about what they can lose by not engaging. So if I've got a tool that helps someone prevent diabetes, am I going to use that if I don't have diabetes? Or am I going to be more interested in a monitoring tool after I have diabetes? You're going to be a lot more interested after you have diabetes. You're going to be a lot less interested about preventing your own diabetes until you're hit with that bug. So another example of this that I think goes well is creating a need when there isn't one that exists, creating a cost preventer when there isn't one that exists. And how do you do that? Habituation. Brett Kinsella has got this great term. He says smart speakers are a gateway drug to using conversational AI, right? Like Siri, Cortana saying Alexa's name, So if that's the case, if I'm habituating behavior for health because I don't have a cost yet, I don't have diabetes, I don't have hypertension, I might not have something else I need to monitor on my own. You can habituate folks, but to do that, you have to have a lot of capital, and you got to have something in their hand already. So one of the best companies in the world that's already done that? And I know this is going to be cliche. It's Apple Healthcare. I got this smartwatch here. They're the #1 watch seller in the world now. And it tells me my heart rate, my respiration rate, how far I've walked, how long I've slept. Did I ask it to do that? No. Could I turn it off? Sure. But have I asked it to do that? No. But all of a sudden, oh, I know how much I sleep now. I know how much I walk now. I'm paying attention to it. So that is one way to do it. The other way is cost. And unless someone has something to lose, whether it be quality of life, death is a great motivator, terror management theory, chronic conditions can lead to that or can lead to debilitating outcomes. That's a motivator for humans. So yeah, I think habituation is the way you create that sort of internal motivation to even care. And you do so by making it interesting to see how you interact. 23andMe, where did I come from? Where's my family? Do I code for various DNA that might give me a certain probability to be at risk for a certain thing? I didn't know that before 23andMe. None of us didn't have that capability. It's a great question. If I had the answer to it, I wouldn't be here. You and I would be probably in Hawaii on my golf course talking about the day that I figured this all out. So I think we have a long way to go with it. But I think those two things are really important. You have to think about what people think about losing, and you have to think about how habituating them into a product awareness can create a new market. Apple's done a great job of that. Amazon's doing a great job of that. But then again, the amount of capital they have to do it is unheralded in history of U.S. business.
Yeah, you hit on something that I think resonates a lot with what Chris and I think about with some of our clients. So you talked in the beginning about how we shouldn't should all over people.
Sure, don't get your shoulds all over them, Audrey. Don't do it.
but the gentle nudge, just the gentle suggestion that pops up on your smartphone or gives you a notification. How do you find their habits and nudge in on them in a way that doesn't tell them exactly what you should do, but just steers them right?
Well, the last euphemism treadmill for this term, a euphemism term on a treadmill for this, Audrey, was big data. Remember when everyone was doing big data? We all did big data, and then you talk to a firm. What's big data? We don't know, but we do it. That's morphed. Data is still the value structure in digital anything, right? The phrase that I heard, which isn't exactly like the most kosher phrase, is data and digital technology in the digital industry. Data is more valuable than cocaine and truffles by the ounce. The valuation from a lot of digital tools comes from the data that you can gain from it. Google email is free, but the monitoring of that information allows them to make $1. And so that's where they win on that. But we've transitioned from big data analytics to tool sets that can handle big data. And now we don't have enough people to monitor the data. And so what's the new industry term that a lot of people don't understand that are still trying to apply? It's artificial intelligence. The difference being 10 years later after big data is that there are real applicable tools and software for artificial intelligence that can give you real results, real insights to how humans are behaving. So to answer your question in a really long-winded way, which I'm really good at doing, Audrey, is that if we can apply the way I interact with my cell phone or my Apple Watch uniquely to me, aggregate that to the millions of people that have these alerts, these software tools, these apps, we can run regressions, which is what AI is. It's a series of regressions and then regressions built on the answers to the regressions. And a lot of times, even in machine learning, some people don't even know how it works, believe it or not. They're still kind of figuring it out. It's a real thing. But those answers net all kinds of outcomes that we wouldn't get with just me, you, and Chris on a BI tool from Microsoft just in our home computers. Let me give you an example from retail. I think retail, because of just the clear supply-demand quotient of it, has some great analogies to healthcare and how we can understand the data. Walmart and Amazon now, but Walmart is just a masterful firm on kind of understanding what the human does in their store. And they've got these long betas in regressions. They've done it. One of my favorite examples is they figured out, first of all, their server center in Bentonville is I think 11 times larger than the IRS's. just to give you a sense of size. It's huge. They're always running regressions. Every time you hear a beep at Walmart, when you walk through and you hear a beep, that classic Walmart beep, what I'm talking about? That sound when they scan an item. Every time that beep goes, there's regressions being run on their servers in Bentonville. Every time. And it measures really wild, interesting things. Weather patterns. If you swipe your credit card, what's your credit score? What's your gender? What's your age? What's your median household income in the zip code that you live in? Where was the item next to? What aisle was it on? What's it currently priced? What was on the end cap, right? The end cap at Walmart usually has the deals. Why? Because you say, oh, there's a deal on chunky soup. And then you're like, what else is on this aisle? And then you stop thinking about deals because your mind can't do that. And you just start pulling stuff off the shelf you need, which translates to increased revenue. But one of the greatest things I remember hearing about them was they figured out that in the Southeast, if there's a hurricane in the Gulf of Mexico, in the Gulf of Mexico, and they had boxes of ever-ready flashlights with batteries, right, in the package, next to strawberry Pop-Tarts that were frosted. They couldn't be non-frosted. If they had those two things together in the front of the store, they would liquidate each box like every 48 hours, as long as a hurricane was in the Gulf. So apparently people like to eat strawberry frosted Pop-Tarts and keep ever-ready flashlights around when there's a hurricane in the Gulf. That's just one example of just like how specific you can get on regression analyses and maybe even modern times, AI and machine learning, to get a sense of how the consumer interacts. Apple probably can do the same thing. Other popularly used apps likely do the same thing, right? The one you're using probably does that as well. That's sort of the future of excitement that is around the corner of unknown as we sort of climb this mountain of data discovery. And there's more data than ever coming through. I mean, voice-enabled tool sets are 9 times the amount of data as search, because when you speak, you could talk a lot in comparison to the physical output of your fingers. That's evolution's sort of gift to all of us, right? The other part about evolution and the human mind is tone, right? Like before we used words and sentences, we heard hemming and hawing and music, and that influenced our emotional state of being. And that emotional state of being gave us a sense of connection or fear or excitement, and you name it. So as voice tools start to become more prevalent in how we interact with our hardware as humans, the sound and the type of sound will become really important as well. The colors that we see also influences us. A red circular LED on my smart speaker looks bad, and it usually is something is wrong. But if I see that happy light colored blue, oh man, something good's happening. Or a little LED yellow, oh man, what's going on, Alexa? What's happening? Oh, you have a delivery. Very exciting. So these are all the things that we can do on top of what we've done in the past with data, that can impart an emotional state of being with these direct consumer tools that has to be added to our understanding of the data itself and how humans respond to it. Don't be mistaken. When those LED lights come up on a smart speaker, to think that Amazon doesn't have that categorized in their data would be wrong. Of course they do. And just adds to the capabilities we've got. So data, tone, social proof, what it costs you, focusing on the intrinsic motivation of the behavior of a consumer, whether it be paying your bill or taking care of yourself. The behavioral science influence upon healthcare and digital healthcare has beyond got started, but it is now sort of endemic in the industry. And if you're not thinking about these things, you ought to.
So this is the best time so if you're not thinking about these things, you ought to. This is the best time to ask the question I have next. And unfortunately, I only have time for a couple more questions. I know that you and Chris have some golf to play in Hawaii right after this. So
never been to Hawaii. I'll be there, bud.
I'll keep it at this question though, mainly because we've talked about this spectrum that includes things like value outside of just the dollars and revenues and things like that, but the quality of life that we can that that anybody who's a healthcare leader might be able to assist their patients, members, population, people with. But when it comes to technology, when it comes to a lot of these innovations, there's organizational resistance. There's lack of understanding from other leaders. And one thing that I wanted to get from you, especially with all these levers of behavioral influence that you're discussing, is for the leader that wants to bring in a digital health solution into their organization, their health system, or what have you. What are some steps that people can start taking or start focusing on to be able to help get their organizations to agree to ramp up in this manner?
Yeah, I mean, this is what makes me a dangerous man across your table, Chris, if we're thinking about doing this kind of work, because it's the master of storytelling and creating a storytelling component with the human interest story. I told you about a patient, and you all probably remember that story I just told just a little while ago. Why do you remember that? It's a good story. It's provocative. It imparts an emotional state, and it imparts yourself in that story or a loved one in that story. Anytime you want to convince an organization to make a move in healthcare, the storyteller will be the master and the human interest story will be the fulcrum. Those are your two takeaways. So you talk about the patients you're serving, the community you're in. You show examples of when technology could have taken you over the hump to something better or would have improved something that was already good. You put your members of the organization, the leaders, in that story as well. You put your rev cycle leader in that story. You put your data management guy in that story. You put the CEO and his or her legacy in that story. You talk about a clinician who's got funding or is well regarded in the community or the healthcare industry or nationally or globally, and you put them in that story. And you look at technology as a tool set, and you look at it as something that can hone and sharpen tools that are already in, the carpenter's bag that you can apply with the community or the problems you're trying to solve. That will get you from, oh, that sounds cool, to, oh, I see how we can use that.
That is a powerful answer. And storytelling, I like the fact that you said dangerous, because knowing that, I mean, the book Influence wasn't necessarily written for people to learn how to influence others. It was to defend against typical levers of influence. So very powerful, but very dangerous advice that you've given to this audience here.
Yeah. Be the dangerous person around the organizational table. Tell the story, or take the time to develop it.
So I want to finish off with, full transparency. Matt and I have known each other for 10 years. I think we talked about that at the beginning of the conversation. And each of those conversations has resulted in, including this one, has resulted in a lot to reflect on. And I want the audience to kind of have that same thing, just whatever, Matt, your final thoughts are, what brought you here, what you're hoping that people can learn, what most people don't know that perhaps they should know. And Audrey, I'm going to give you the same question too. But Matt, just wanted to hear from you. There's a reason you came on here today.
Sure.
What would you like people to take away from this?
Well, I came on here today because of you, Chris, number one. I trust you. You've built a great community for yourself, as I've been building communities, and you're part of my community. So that's number one. Number two, I don't see success happening without building a community. And to do the things that I want to accomplish when it comes to innovation, technology, and leaving something that matters to patients or organizations across the world or US, I have to build a pretty large community, and I have to do it digitally because I can't be in all these places. So creating these kinds of conversations are not about answers, but about defining problems. So that's one thing. The other part is what I've mentioned already. Stop thinking about things from a moralistic place with healthcare. Stop doing it. Don't do that to somebody. It's impossible. It's fun to think about. There is virtue in it, yes. But the more realistic questions to ask is, what's the intrinsic motivation driving this patient? And how do I create a system around them to get to a place that actually is useful for them? That's a hard thing to do. But it's more important, I believe, than sitting around talking about lofty ethical constructs about the shoulds and missing the human connection to the people you're serving. Those are my two takeaways. build community, think about intrinsic motivation.
Appreciate that. And any final thoughts from you, Audrey?
What a great ending. I'm not sure how to top that. I think one piece that I really liked was you talked about craft this story and put all these characters in it. And I'll put one more character that I think helps tell a really compelling story. And that is find the naysayer and befriend them. Find community and relationship and connection with that naysayer and help them be a part of the better story. If the technology isn't working, then bring them on board and have them help you get it to a place where it does work. So I love what you said. I think it is about telling stories, and it's about finding the people to be in them. And I would encourage folks to find the folks who are resistant and don't be intimidated by them. Bring them along.
Audrey, I want to yes and you. Karl Popper, a famous philosopher of science, said, science's goal is to find out what's not working. And the more that you find out what isn't working, the closer you get to an objective truth. So absolutely, get the gadfly in the room and tell us what isn't working here. So nicely said.
I'm going to yes and on that one too, is that just because somebody's a naysayer, just because they're voicing a disagreement, doesn't mean that's a personal attack. Doesn't mean that that they're fundamentally disagreeing with you. They might have like a lot of clinicians that we've spoken with in the past have been naysayers because they're the most tied and most connected, have a significant amount at stake if something is incorrect or goes wrong. So I appreciate the naysayers. I'm looking for that feedback. And I think that so long as it's not hostile or aggravated, there's a lot of growth that can come from that.
Yeah, healthy discourse really matters. Talking about what's not working really matters. The story really matters. This has been a really wonderful conversation, Chris. Thanks for curating it with Audrey and I.
Appreciate you, Matt, and Audrey. Thank you for coming on as well. I think you brought a lot of light to this discussion. And signing out, I hope that this has given you a lot to think about over the weekend. I hope you've enjoyed it. I hope maybe if you've had a bad week, maybe it's been a bright spot where you could sit back and just think about overall big picture stuff and not have to deal with all the aggravating particulars. Signing out, just want to drop another reminder. A lot of these conversations, we bring those into our new podcast, Hello Healthcare, where we go really deep into this subject matter. Last episode was about a couple of organizations that we mentioned, Walmart and CVS. We actually did a deep dive on that podcast with regards to the so-called disruptors in healthcare. And next Friday, same time, Ed Marks will be bringing Ed back to the table to talk about the patient experience specifically. Ed, for those that aren't aware, formerly Chief Information Officer at Cleveland Clinic, and now Chief Digital Officer in Health and Life Services at Tech Mahindra.
That sounds great, Chris.
Come on board, hang out with us in the chat section.
Sounds good.
Yes.
Hey, Matt, where can we get your book for our listeners?
Oh, thanks very much. Yeah, I've got my book's coming out in the next 60 days, Voices of Healthcare, the Digital Acceleration. And we've got fantastic people in there representing Teladoc, Google, City of Hope. We've got it all. And patients, ALS patients, adult patients, pediatric patients, all talking about their experiences in healthcare and digital health and their hopes and dreams, even designers and creators. Grammy Award winners. We had some Grammy artists talking about being involved in creating music for voice apps for hand washing during the pandemic and their views on healthcare in general. It's going to be available on Amazon as well as a few other publishers. So follow me on LinkedIn and the announcement will come out and I'll have a link to all of it.
Thank you.
Yeah, you're welcome. Thank you.
Thank you very much. Thank you for everybody who joined us. Sorry we went a little bit over time, literally doubled the allotted time, but
oh, wow.
I thought it was a great conversation, and I mean, everybody stayed engaged towards the end. So I'm just really appreciative that everybody was interested in this subject. But that's all we have for the weekend, folks.
All right. Thank you a lot.